Okay, hello. You want me to start?
Welcome, Dr. Malek. Welcome, Dr. Alexandre, Dr. Fadi, and all attendees, Dr. Mohammad Kalakesh and Dr. Safa. I present you Dr. Malek Mohammad, the head of the LSC board and the president. He will introduce our webinar today. Thank you for attending. Dr. Malek, you can proceed.
Good evening, dear colleagues. I'm sorry I cannot hear you well, but I will start as I noticed from your, yeah. So good evening, dear colleagues, and thank you all for attending tonight's session, which is the second session in revascularization after the last week's session on complex PCI bifurcation left main techniques. I hope you and your families are safe in your home, in your work, and I also hope you are still healthy. And I'm sorry to say that it is a very dark period that we are passing through these days. It is with extreme sorrow and difficulty, but we still try to gather, communicate with each other in order to continue to receive our education, training, and try to benefit most from what we get for the sake, and this is all for the sake of our patients. I and the Lebanese Society of Cardiology would like to, first to extend our gratitude and thanks, also appreciation for Terimo, which is the sponsoring company for today's event, and definitely for its continuous contribution in this very important field, which is the CTO field, beside many other revascularization fields. Also, a special thank for our guest, Professor Alexandre Avran, a highly esteemed and experienced operator, definitely an eminent speaker in his field, whom we are proud to have him among us. And I'm sure that we all will learn and benefit the most from his rich experience and knowledge in the CTO revascularization field. Thank you, Professor. Thanks for my friends, Dr. Fadi Abou Jaoude, Ali Sayed, Ahmed Serhan, and Mohammad Kalakesh for their precious time they gave in preparing, organizing the session tonight. And I'm really proud to have you all among us in the Lebanese Society of Cardiology. I would like to open today's session on CTO tools in ordinary daily practice, which we all know. CTO PCI is a complex PCI. It comprises around 5% of all PCIs done. That is used to be of high rate of complications and of high rate of failure to revascularization. We, as interventional cardiologists, were discouraged from embracing this procedure in the past. However, thanks to the progress of technology and to a greater operator experience, the percentage of successful revascularization rate has increased markedly over the past few years, reaching more than 90% in selected centers, and we hope to follow their traces, with also a number of complication and adverse clinical events that also significantly dropped. Although the randomized clinical trials conducted so far have failed to show superiority of CTO revascularization strategy over medical treatment alone in terms of hard endpoints, yet we have many observational studies and meta-analysis suggesting a wide range of benefits of interventional treatment, like improved health status, improvement in the quality of life, and definitely improvement in the symptoms, especially in those patients who have the highest degree of ischemia, and definitely those patients will receive a greater benefit from CTO revascularization. So today's session will go over 2 case presentations that will discuss every single step, and we will try to answer as many questions as time will offer to us regarding the strategies, the steps, and also we will tackle two topics about wire selection by Dr. Fadi Abou Jaoude, and the CTO tools will be dealt with Professor Avran. And definitely we will have a moderation from Professor Avran, from Dr. Abou Jaoude and Ali Sayed, and Professor Avran will be available to answer any question that is related to this topic. And it will be over 2-hour periods, as we know. So let us have your question in the Q&A box, and in order to get an answer after each case and topic discussed. So first I will call on Dr. Ahmed Serhal, who will present the first case in our session for tonight. Please, Ahmed, begin. Thank you.
Good evening. Thank you for the LSC and for the intervention working group for this kind invitation. And it's quite pleasure to present in the presence of Dr. Avran. I present a case where it's a mix between acute ST elevation MI and where the CTO tools were invited to help us to get out of a very challenging situation. So, sorry, I cannot. Okay, so it's a 54-year-old gentleman, a heavy smoker without any previous medical story. He presented with at 1 hour of acute chest pain with to an emergency department, and his EKG show inferior ST elevation MI. He was stable hemodynamically. He was loaded with aspirin, ticagrelor, and heparin, and he was transferred to private. This was done in a center about 40 minutes from our center. So we note his left coronary arteries. We have a tight stenosis of the obtuse marginal, and we note also a tight stenosis at the bifurcation of the mid LAD diagonal. And as we are in the CTO session, we note the presence of these precious collaterals to the right coronary artery in this incident. This is a shot for the right coronary artery. It's an acute total occlusion of the proximal RCA. This was done with GR4. Many attempts was done with a guiding GR4. The sequences was omitted for the sake of time, but the support was not good. So the operator chose to move to a non-left guiding, and after many attempts, he successfully restored the flow. But I don't know the guide wire still approximately. before the lesion. This is the RCA. So also after many attempts, he had the guide wire somewhere without and with the disappearance of the flow. It's a Timmy flow 0 again. So he got a balloon and he tried to inflate the coronary artery. Many attempts was done. And we got this image of the dissection. And this is 10 minutes later. And also 20 minutes later, he removed all the material, and we have this large hematoma. So the patient was transferred to our center for emergent surgery. The patient arrived in severe pain and really in important agitation. He was hypotensive. A fast echo showed mildly decreased LV function, but severe RV infarct. So after discussion with the surgeon, we opted for a rescue PCI attempt. The plan was to do ADR. The dissection is already here to try a re-entry. We called the anesthesia to have a deep sedation and a calm environment. So I will show you this the first few before discussion. I opted for our left radial. I wanted to go by 7 French, but I couldn't from the radial. So it's a 6 French AL075. And I started with a run-through soft wire with the support of over the wire balloon to try not to inject some anterograde to avoid the extension of the hematoma. Yes, this is what do you consider to do in this?
You intubate the patient and the patient was stable now, or?
He was not intubated, but he was calm under inotrox, but he was calm with the presence of the anesthesia.
What is your plan here? What do you intend to do? Is to try to go from the beginning in the true lumen, or to go through the dissection and do a distal re-entry? What is your plan here?
Because of during the first procedure, there was a ballooning in the false lumen. So my belief was that there's no chance to get the true lumen from the proximal part. So my plan was to take a wire to go as far as I can with over the wire balloon, and to try to re-enter in the true lumen and to check this with a distal injection. This was to try many techniques: parallel wire, re-entry, soft hard escalation wires technique, and to check this with a distal tip injection to avoid injection, anterograde injection, and the extension of the hematoma. This was my plan.
Dr. Alexandre, in this case, we see an ST elevation MI and a rescue PCI with many hours after. And the question here, should we go by dual injection, knowing that in the first was right was reperfused distally by the left system, or we can try with our AL1, knowing that the ST elevation MI, and we can pass the probable CTO in the mid lesion through a thrombotic lesion was easier. What do you think about it?
Okay, so here the point is that you have a dissection due to the previous attempt, as you said. So if you go antegrade, most of time your wire will be in that dissection. So as you are prepared to do like ADR procedure, so a CTO procedure, I think you should have a dual lumen injection. A dual injection means you should see the distal right coronary with your left injection. And it will be okay for ADR like this, or maybe you can go also retrograde. And retrogradely, maybe there is easy septal. You will avoid to have a long subintimal tracking of your wire. And maybe your wire retrogradely will go in the true lumen, true to true. But if you don't plan to go retro and you plan to have an ADR situation, you need to have the distal landing zone visualized by the retrograde injection. I think it's mandatory here because you can't go with your wire. With most of time, your wire will be in subintimal and you don't know where is the true lumen after. So you will, it's not good to do a star, like a star and try to go with a knuckle inside the true lumen. So in my situation, I will use a second left guiding catheter to visualize the distal right coronary.
Just one comment. As it was an ST elevation patient on inotropes and sedated by the help of the anesthesia, it was not very calm first. My plan was to do so my plan was to go from anterograde. I was not really planning to go by a retrograde. And my first plan, to be honest, was to cross with the microcatheter or over the wire balloon once if I can catch a true lumen distally to be sure of my position of the wire. This was my.
How you will be sure that your wire is in the true lumen without a retrograde injection?
Exactly. That was what happened during the procedure and was my next step.
What did you do, Dr. Sahal? Can we see what you did?
Okay. Just to note here, I successfully passed after not lot of attempts in the distality of the RCA, but as Dr. Avran mentioned, I was not really sure that I'm in the true lumen. I tried to cross with my over-the-wire balloon, but I was stuck in the distal RCA as you see it here.
What did you use as wire?
Here it's a run-through wire. I wanted to go by a soft wire, then to escalate if needed. By my run-through wire, go distally. I was not sure of his movement and of the position. So as Dr. Avran mentioned, I opted for a second dual injection from the left coronary artery to be sure of the position of the wire. Retrospectively, I think I was in the true lumen, but to be honest, the movement of the wire was not reassuring, and during the life of the procedure, I was not sure I was in the good branch, and I was more confident to try to get either the second branch in the posterolateral, as you can see it, or the PDA. So I started again with a parallel wire technique. So here I took another. I tried with a pilot, then with a Sion, to as a parallel wire strategy.
Which pilot? Sorry.
I tried with the pilot 50 with the help of the over-the-wire balloon and many injection. I tried to get in the PDA or in the second branch of the posterolateral, and I was successfully able to cross in this second posterolateral. And I took many contralateral injection to be sure I was in the true lumen. I don't know here with the videos, but of the movement of the wire, and during the procedure, there was a clear opacification of the position of the wire in the branch of the posterolateral. So here I balloon was a 2.5 balloon in the distal where my over the wire balloon was stuck. I just ballooned this point. And here, how would you deal to stent this artery? What do you suggest at this level?
Okay. May I have a question? How do you explain that your over the wire is stuck at this part?
I think it because it was my re-entry point. That's
Okay.
my
So it
my
means
belief.
your re-entry point is very far away.
Yes.
Okay. And is your re-entry point is before the crux or after the crux?
It's at the level of the crux or just after the crux.
Yes. So it means that if you plan to stent, you will lose, for example, the PDA branch or the RV branch, one of the of this branch, because you have to be sure that your re-entry point is before the crew.
I totally agree, but maybe in the on the context of the acute phase, I was how I say sure that maybe I will lose the PDA, but as I was in the situation of acute phase and rescue PCI, I accepted to just save at least the postulator. This was
Okay.
my thinking. I tried to be honest. I don't have a dual lumen here. It would be an excellent tool to use it. I think to puncture the postulator. I don't have it on the shelf. It's a very useful tool to try to puncture. I tried with a single over the wire to puncture again to the PDA. I tried, to be honest, with a Pilot 50 and with a Gaia first, no more aggressive than this. But I didn't get to the distality of the PDA.
Okay, good. I think the dissection is extended beyond the crux. So why you don't stand before the crux, from the crux to the ostium, and you will see what you will have. Okay, it may be in the second time, or you can continue and you can assess what you save and what you didn't save. And sometimes you will be surprised that the PDA is safe.
Excellent suggestion. My strategy was to make a distal injection on the posterolateral and to see what is the level of the dissection. So I make the distal tip injection to see that I have a very extended dissection, even beyond the crux. So at this level, with this injection, I was not really sure that if I stented just at the level of the crux, I will have a good result to the posterolateral. I thought about this idea and we'll see. And one suggestion is to do here was to stent and if available to dissect the hematoma with a cutting balloon. One of the tricks suggested, also unfortunately not available on the shelf. So I decided to save the posterolateral after this injection because I estimated that the dissection extended really beyond the crux, more than 15 millimeter beyond the crux.
We know in our cath lab that the microcatheter is not really available to every patient. And upon the insurance of the patient and how it will pay for that. But in these cases, knowing that really is an acute on a CTO lesion, that the thrombus was the proximal, but the CTO is more likely distal and diffuse. The issue is we cannot balloon it. We can balloon it, but we don't have to do injection. Most likely the contralateral injection that will ask us and put a map for us to do that. This is really is not a chance and a possibility to go for a double lumen microcatheter to puncture the PDA and to see where we are and to see. For Dr. Alexandre Avran, for the hematome that is realized in the 3 hours before, will reflect in our strategy here. Do we need to, like we see some tell about aspiration of the hematoma, or like Dr. Sarhal saying about cutting balloon? I'm not really with this issue with a context of an ST elevation MI, and we don't know really where we are, and we don't have really an IVUS to see is we have the extension and the diameter of the vessel. We know you know better. You worked a lot in Lebanon, and you know our resources is very limited.
Yes.
In our daily practice, we know your opinion how to not use a lot of materials and to have the best result can be made. And Dr. Sarhal had till now a very good job with over-the-wire balloon. What do you think about the over-wire balloon?
Absolutely. No, over-the-wire balloon is a tool to work for CTO, but the difference between over-the-wire balloon and microcatheter is that the over-the-wire balloon direct the wire. And with the microcatheter, your wire is free to go, and this is the microcatheter is following the wire. So it's a little bit different because the over-wire balloon will straight the wire, and sometimes the wire will go straight forward and not going inside some curvy part. Okay, but if you are here, the point you are in acute coronary syndrome, it's a safety PCI. You have to save. So okay, beyond after the crooks, okay, but is in the true lumen. What you can do is what you did, some parallel wiring also with the other wire balloon, but maybe try with a little bit of wire, because I think Gaia first is maybe too low tip load here to just cross the flap of the subintimal part. And if you try with some Gaia third, for example, maybe, so you just want to be in front of some small resistance, because the resistance will be the flap, and then just get in the direction of the PDA, and with the retrograde injection, be sure. But if not, I think what you can do also with low is just, okay, to stent your from true lumen to true lumen, and then maybe go back in this patient some weeks later, just to see if you can get inside the PDA antegradely or so. It will be, maybe the patient will be more stable at this part.
Thank you for your excellent comments. Thank you for your excellent comments. At this level, as you mentioned, I decided to make a full metal jacket. At least to save the posterolateral. So I stented, avoiding to inject anterogradely. So after putting 4 stents with a full metal jacket from 2.5 to 4 stents, I had this result. The patient was relatively stable. I was lucky to preserve the RV branch also. So after this stenting, I hadn't attempt to try to puncture the posterolateral, as I preserved two branches of to get the PDA, and I preserved the 2 branches of the posterolateral. And this is a control 10 weeks later. I had the persistent good result while I did the PCI for the left system, and with a collateralization preserved to the PDA.
Can we see do you have the collateralization? Can we see the collateral from the left system?
In this injection or in the second procedure?
Yeah, of your control procedure. No, do you have a, no, it's okay. I just,
not available just here on this laptop, unfortunately.
Okay.
It goes with the main septal.
Good.
The main septal. So my take-home messages for this complex situation to limit injection from anterograde, to limit the hematoma extension. Just to note that the lesion was just at the level of the first curve of the RCA. At one level, we see the distality of the hematoma. It was a very focal lesion. With ballooning, I think with a 3O balloon, we have all the extension of the hematoma till the end of the crux. So unfortunately for this patient, we could stent it for, let's say, 30 millimeter stent, and I ended up by 100 millimeter. Retrograde injection, dual injection as a tool from the CTO could be really savior in even in acute phase. The use of microcatheter to check the position of the wires, to change wires, to try to get to the side branches. It's important tool that we can take from the CTO to the our daily practice. Parallel wire technique also, it's very important in CTO, but also it's very important to have dissection reentry or to get through the true lumen in a complex non-CTO case. And the use of cutting balloon, maybe it's recommended in the spontaneous coronary artery disease. I don't know in this setting of iatrogenic dissection, it could be, it could limit the extent of the stent. And prevention, it's useful in CTO, and it's always useful in our daily practice. Not to balloon if we are not sure of the position of our wire and of the mobility of our wire. The use of microcatheter or over the wire balloon to check the distality before using large balloon could be very important to avoid this terrible complication. Thank you.
Thank you, Ahmad, for this lovely case. Thank you for the take-home message. I will continue with Dr. Fadi Abou Jaoude that will have an overview of wire selection in this setting of complex PCI. We'll proceed with Dr. Fadi. Thank you, Ahmad.
So, good evening. I have a small presentation concerning the basic principle of wire manipulation in CTO PCI and CTO-like PCI. So here the target of this small talk is to show you that we have many wires, and each wire, and in each situation, we have a special manipulation. Thank you. Oops. Okay. So these are the different shapes in general we have. Try to choose which shape we use in general in CTO or CTO-like procedure in your mind. The question is those two shapes. The first one is to do a 1 millimeter between 45 and 60 degrees angulation, and sometimes we need another band here, a second band done at 3 millimeters. These two shapes of the wire are useful in PCI and CTO PCI or CTO like PCI. Second, especially this talk will talk about some terminology. What are the words used in CTO wires? We have to understand how to do a puncture. What means a puncture? Push, deflect, and torque. What means drilling, sliding, surfing, and knuckling. First of all, the puncture. The puncture, it means when we have a resistance in the plaque, we have to cross it. We have to puncture it. In general, we use heavy loaded wires, example, the CP12 or Hornet 14. And these are used to cross this resistance. In general, it is or the proximal cap or sometimes the distal cap. When we are doing a puncture, we need a torquer in general. It's not advisable to do a puncture without a torquer to help to over control the over drilling. Drilling is used when we do a puncture, but the over drilling is not acceptable. Example, it's enough to do a small drilling, gentle drilling, and push the wire in the plaque. And with the heavy load tip of the wire, we can do a puncture, okay? This is a puncture you see here and here. This is a microcatheter, and we do a puncture at this level. Second, what means push, deflect, and torque? It is in some specialized wire, like the Gaia. The Gaia is a wire in general used to cross microchannels. Okay, when you have a microchannel, you need to cross it. Gaia is an excellent wire to cross these microchannels. But how to manipulate? We have to manipulate this wire properly. Push, you push, deflect, and torque. Push, deflect, and torque. Okay, and the wire will find his way alone. Okay, it's a push, deflect, and torque. For example, sorry, I will advance for the sake of time. Okay, you see here, for example, the wire, we push it, we deflect a little bit, we torque, and we will advise. Okay, here, look very well. We push the wire. This is the microcatheter, and the wire is just outside the microcatheter. We push, we deflect, and we torque, push, deflect, torque, and until he will find the right way. Once we cross the lesion, we change by the microcatheter, we change the Gaia by a workhorse wire. Okay. The puncture. Second, push deflect torque is a specialty of the Gaia wire. The third is drilling. Drilling, in general, we use this manipulation when we have a polymer jacketed wires. Drilling is like this. When we have a resistant plaque, difficult to cross, so we do a drilling, okay? We do a drilling with a torquer, it's better, but sometimes we do a drilling, ultra fast drilling without torquer, okay? Two techniques. This is drilling. Sliding, that's what we use in all, with all wires when we do a regular PCI. When we cross the lesion, we do a sliding. Sliding, it's enough to push. You can torque a little bit and push the wire to the end of the vessel. Okay? For example of drilling and sliding, for example, look at the right. You have a total occlusion, but it is a straight with tapered proximal cap, no angulation. We use, for example, here, we use the Fielder XT. We do drilling with the Fielder XT, and this wire will find his way alone. And when we cross the lesion, the obstacle, we continue by a sliding to the end of the vessel. Okay? So, sliding, puncture, deflect and torque, drilling, sliding, surfing. Surfing, in general, we use surfing with a specialized wire like Cheyenne Black, and Suo. The aim of using the surfing is when we want to cross from, for example, the LAD to the right. For example, we use the septal branches, and we'll try many times to go in the septal branches, and the wire will find his way alone. Okay, now we are in a good way. Okay, we cross to the right. Knuckling, two wires we can use to do a knuckle, two wire, the Fielder XT or equivalent, and the Pilot 200. Knuckling, I will show how to put, we do a knuckle and we push it. Okay, we do a knuckle and we push it. I will show you a case here. For example, here, you see a right occlusion, okay? A right occlusion. First of all, we put our microcatheter and we do a puncture of this proximal cap with the CP12. We advance the CP12 and the microcatheter. And you see here, this is a knuckle. This is how we do a knuckle, okay? We advance the Fielder XT and we push it. We see the knuckle. The knuckle is in the in the vessel, but outside the lumen, okay? And we push it in some technique. This, the knuckling is very important to do many techniques in CTO or CTO-like procedure. We can do it in the proximal, or we can do it in the distal cap, retrograde. Look here. We do a knuckle here by the Fielder XT and try to push him back in the right. We are here in the dissection, okay? In the vascular structure, but in the dissection, not in the true lumen. You see, because the knuckle is large. Okay, and we push everything. I am in the structure, extraluminal, but in the vessel, and we finish by doing another knuckle from antegrade. We do a reverse cart, and here we have the final result. So In CTO or CTO-like procedure, we have to know some how to manipulate each wire, how to do a puncture, what means push, deflect, and torque for Gaia, what means drilling, sliding, surfing, and knuckling are essential maneuvers to master in CTO PCI. A limited set of wires is required to perform those tasks. Thanks. Thank you. For the sake of time, I will not continue to show you another case. Thank you.
Thank you, Dr. Fadi. There was one question from Dr. Randa Tabba. Could you give us an idea about the indication for the use of the over-the-wire balloon, and in what specific case is best used? What do you think, Dr. Avran? You already explained about over-the-wire balloon. Do you see any other indication to change the wire in a complex cases taking place of a micro catheter? Do you see other indication of the over-the-wire balloon?
In fact, you already answered to this question. It means that if you are in a very complex situation with some calcification or tortuosity, and your first wire cross the proximal part just before the stenosis, and the wire balloon can help you to exchange your wire. It means you are with your workhouse wire, so for example, run-through wire, and the run-through is not able to cross this very complex part. So maybe you need to use a softer wire like Scion wire, or you need to use a softer wire like maybe run-through floppy, or sometimes you want to exchange for extra support wire, and so you just exchange your wire with the help of the over-the-wire balloon and not recross everything with your extra support wire.
Thank you. We'll go with the next case with Dr. Mohammad Kalakesh about an interesting case as we face in our daily and will be a nightmare for us, how to try to get and to over these complex lesions. Thank you, Dr. Mohammad. You can start.
Thank you. Good evening, everybody. Thank you for having me tonight. In fact, about 10 years ago, I was called for a young man who's having an inferior MI. He was really young, and it was a huge right occluded in the middle. And at that time, we have the wires. The maximum one was pilot 50. And I tried for 4 hours to recanalize the right, and I failed. And then a few years ago, I went to a lovely city called Nice with my friend Ali at Dr. Avran Cath Lab. My aim to learn CTO was to really tackle the really daily cases, which are acute or subacute, and they are complex, and to have a new perspective, because I think we have more complex than we have a real CTO here in Lebanon. So I'd just like to share this case with you, who presented late evening or early afternoon to our emergency unit. And he was really in cardiogenic shock. He was pale, tachypneic, blood pressure barely detectable. And he was suffering from severe chest pain that turned to be over the last 3 days, for which he was receiving non-steroidal anti-inflammatory because they thought it's a shoulder pain. And his past medical history was really negative, but he was really in big trouble. And we started him on inotrope and a little bit diuretic because he had a little bit basal crackers on his lungs. And his EKG showed cues. Yes. He had by EKG already cues on the anterior leads and nothing else specific. And we already managed him and took blood test, and his troponin T, which is highly sensitive in our hospital, was more than 1,000. CPK-MB more than 300. and we transferred him, and he received already the protocol and was transferred to the cath lab. This is the right. It has subocclusion proximally and maybe a CTO distally, if it shows on the. This is another view of the right. And this is the left system. The circumflex is doing fine. At the first glance, we thought that this was the LAD, though it's a huge diagonal, and that the LAD is somewhere here in the middle and shows almost a CTO or a complete occlusion before the severe lesion in the proximal diagonal. And he has also a severe lesion in the proximal LAD. It is night, and what you do to this patient? Give it hot.
On the EKG,
Anterior cues and the anterior leads. He has a severe lesion in proximal right, maybe a CTO or total occlusion in the distal right. We have total LAD at the very bad place. The second image we realized that the first image we thought it was the diagonal, it's the LAD, but then we realized that it's a big diagonal and the LAD is occluded somewhere in the mid part. Here another view. This is a left anterior cranium. So it's a huge diagonal, occluded LAD, severe disease in proximal LAD, circ acceptable, and we have shows some collaterals to the distal right, to the PDA. So what we doing for this patient? He already received the Brilinta and started on Agrastat, because in my cath lab I always do for emergency, who are transferred within half an hour to the cath lab. I prefer to start Agrastat with Brilinta, aspirin, and the whole protocol. So what you do?
Mohammed, most likely is a like double vessel disease. The culprit, as we showed, has a diffuse disease on the LAD with an occlusion of the mid LAD with the severe stenosis of the diagonal. Most likely the culprit lesion, as we see up in the EKG and up in the cardiac cath, this the LAD. You have to tackle the LAD in first choice. I don't think we start, because his in shock cardiogenic will go to the culprit lesion. Knowing that he have a Q wave, and this is like about timing of the revascularization, but with the patient is clinically is not good, most likely we try our chance to open the culprit lesion, and if any viable tissue will save it. What do you think, Dr. Abou Jaoude?
okay. Did you do echo and a cardiac ultrasound? Do you have any idea about the?
We did an echo post-procedure. It was about 20%.
With anterior or inferior?
With this 15 to 20%, it's looked like a global. You can, I couldn't know, so it was a really the whole myocardium. I can't detect which wall was the responsible, though I believe it's the anterior, which is most, and the right is a little bit chronic.
Okay.
But my strategy was to go for global revascularization. Since he's in cardiogenic shock, I will recanalize all I can.
Okay, so if you can consider that the LAD is the culprit vessel, okay? So we have to start definitely by the LAD, especially that the flow in the right is TME3, so there is no justification that to start by the right here, I think so. Do you use here, it's rational to use a special device like intra-aortic balloon pump or other thing in this case?
No, because I don't have it. In this cath lab, it's just cath lab. We don't have
Okay.
surgery.
Hemodynamically, he was stable.
Yeah, he was started on levofed, and he was started on low dose dopamine.
Okay,
And,
so he's not too stable. Okay,
no, he's not too stable, definitely, but he's not.
If you have the luxury to use any device, do you choose anyone? For example,
if I
Impella.
have, an umbrella.
Impella.
Yeah, if I have the option.
Okay.
Definitely.
It will be
But
a good
to start
indication
with,
here.
at the time I started, I've shown many cases, and it's not a choice to use it. I can handle it. Unless he deteriorated more or I couldn't recanalize the LAD, I definitely go to these devices, intra-aortic balloon or Impella, if I have them.
Okay, excellent. So what will be here your strategy? Please tell us what will be your strategy.
My strategy was to start with the left system, recanalize the LAD and diagonal if I can. If I succeed, I will go to the right. If I failed, I may consider surgery.
Do you think
it's a high risk?
Do you think intra-aortic balloon, Dr. Abou Jaoude, will put some more, because all studies that done about intra-aortic balloon doesn't really ameliorate or change the mortality rate in cardiogenic shock. You will be stable in your table and you will be like, yeah, I feel good, I have an intra-aortic balloon on it. But really did change your strategy? Did you use for Impella? For sure, Impella have his positive input about cardiogenic shock and complex PCI, left main and the low EF. For sure, Impella, I am with you. But intra-aortic balloon, does we need it? I use it in France like years ago, but after all the study and the meta-analysis doesn't show very much. Well, what do you think, Fadi, Dr. Avran? What do you think about intra-aortic balloon?
In fact, we have a subjective feeling that it would help, but in all the studies are against. So I think it's not justified here to lose a lot of time to put a intra-aortic balloon pump and to go straight forward to the PCI. So tell us, okay, you will start by the LAD. Any idea about the technique, the material you want to use, the wires, the balloon, microcatheters?
My technique is the escalating technique. I start with the PT2 wire. I have a strategy escalation of wire.
Okay.
So this is my workhorse catheter in these cases are the PT2 from Boston. So I went with the PT2 wire, cross all through into the diagonal.
Okay.
And make ballooning to the diagonal to recanalize it just after the uptake of the LAD. Because this PT2 wire can in no way go into the LAD. So I put it in the diagonal, make little bit dilatation to the diagonal. And then I dilated the diagonal, and then I start to tackle the LAD. And the PT2 sure cannot go in, but I use it just to put it at the proximal cap to the LAD, just to introduce my over-the-wire balloon, because I have the microcatheter, but for financial reason, I can't use it. So I put the PT2 here, I introduce my over-the-wire balloon. This could help us. This is a way to use the over-the-wire balloon. The CTO wires, you cannot deflate them and you cannot introduce them till here. Over-the-wire balloon, it can help you to put it in the front of the proximal cap so you can exchange wire. So I use a PT2 wire just to introduce the over-the-wire balloon till the proximity. Then I use extra support, whisper extra support wire. I could not do nothing. I use a pilot 50, then 100. I could do nothing. Then I choose Filter XTR. And then with the Filter XTR, I start to have some result. And with a little bit the next step, Well, okay, we'll discuss it.
This is the status of in cardiogenic shock. You have a subocclusion of the RCA, and you really realized a wire in the diagonal, but you cannot cross the occluded lesion on the LAD. And most likely, and we see the LAD is very calcified lesion and multiple stenosis. Most likely, there are an acute occlusion over a CTO lesion calcified long time ago. Dr. Maroon Suede suggests that as the diagonal is really big, you can start the diagonal and then try to do the LAD. Why you go to the LAD and not really going to stand the proximal part of the diagonal?
Sorry, it was second option, but it's really when I just balloon the proximal and mid diagonal, the patient was still in pain. And I said to myself, since I know CTO, why not to give 10, 15 minutes to try to recanalize LAD? Because if you can recanalize the LAD, you will save a lot of myocardium. But in case I could not recanalize the LAD, the second plan, and surgery is out of question, was to recanalize from LAD, proximal LAD, till diagonal, and then go to the right. But I said, since I have the tools, let me try to recanalize the LAD. He's still in pain, despite I recanalize the diagonal. And let's give a try using the CTO technique to recanalize the LAD. The only problem with the LAD, the proximal part was severe with an angle. وما عندك big support. But the second plan B was, if I fail to recanalize the LAD, go stand from proximal LAD till distal diagonal and do the right.
In fact, here you are not seeing very well the LAD,
Yes.
so you don't know exactly where to go. Why you don't do a dual injection through the right? Maybe you will see it more. It's not seen?
We took right anterior.
Okay, so it's an acute.
Could not see it. But when later on, when we start to tackle the inlet here, we start, if you can see it distally, we start to see the shadow of the LAD. I cannot know because we transfer from film from machine to machine. But we have the ostial of the LAD here, the ostial after that. If you can see it on the screen, you can see the inlet of the LAD here after the bifurcation.
Okay.
Here we can, using the filter XTR, build the cross with the help of this 1.215 over the wire balloon. And then sure when I was sure I am inside, I exchange and put a PT2 wire.
Mohammad, I want to ask you, you go to the pilot 50, 100, 200, and then you go back to the filter XTA or STR?
XTR.
XTR, you escalate and you de-escalate. What do you think about this escalation and de-escalation, Dr. Avran? Seeing that is a acute onset and then occluded LAD, what do you think about this escalation and de-escalation? How we think in CTOs and in acute lesion, how we will go for an escalation and how far we go by escalation and how we can go back by the escalation? What do you think?
I think here it was very wise to desescalate because, as you said, we can't see the distal part of the LAD. So it's very dangerous to go with a stiff wire. So going with XTR was the best way to go because XTR is not able to go subintimal and it's a safe wire. And as you see, the wire went just straight forward in the LAD and without a knuckle situation. So you are pretty sure in that situation that your wire is in a lumen. So it seems to be the LAD lumen, but we are not sure until we can see it. But okay, the point is in CTO, for example, as Dr. Abou explained, you have many steps. For example, you are in front of some very hard cap.
So your first strategy is to puncture. So you will go with stiff wire, as Dr. Abou said, like CP12 or Ornet 14. And then when you cross the proximal cap and you cross with your fine cross or your over the wire balloon, then you can desescalate with some soft wire to be safer.
Okay, my question for you, Mohammed, and for Dr. Avran. Here, when we don't see the distality of the LAD, do you use, as you mentioned pretty well, it's dangerous to use hard wires, okay? We can go easily outside the vessel. But do you recommend to use here supports like micro catheters? Okay, nobody is hearing me.
Yes.
Are you hearing me?
No, totally. I'm hearing you
Yes.
very well.
Okay, so I will try. Maybe we have some. Are you? They are hearing me. Okay, so do you use here over the wire balloon or a micro catheter, which may increase the support of the wire, so even the Fielder XT can easily go outside the vessel,
So,
or maybe you lose your feeling.
yes. So I will use, in that situation, I prefer to use a microcatheter, because with microcatheter, I will not lose my feeling. But the point is not to increase the support, because it's an acute coronary syndrome. So as you see, the Fielder XTR cross very finely, very easily. But here, the use of the microcatheter is to do a tip injection. So I will following the wire, my microcatheter, the mid part of the presumed LAD, and just see if I have some reflow. And if I have some reflow, I will do just a tip injection to be sure that I am in the LAD, not inside septal or renal, and then I can predilate.
Okay, good. Continue.
Dr. Avran, I want to ask a question. In the setting of CTO, we know where we are. We know that we have a include lesion, CTO lesion. We can do an injection by contralateral. In the case of an acute case, in this case, we not go really typically by double injection. And in this case, we are
Yes.
unconsciously, we go to more and more injection. And really, how we can go? You ask about tip injection by the microcurrent, but that after we cross the lesion. But in these cases, and we have to do more and more injection. We're trying with escalation of wire. How the risk of hematoma can be here present, and we can complicate the situation more than facilitated.
I think you can't more complicate the situation because the LAD is already closed. So the only way is to get better for the patient. So I think here it was very hard to be sure and to find the stump of the LAD. But when you find the stump, I think it seems to be easy to cross. But I was not the operator, so maybe he has to answer if with the Fielder XTR, it was easy to get in the distal part of this artery. But the only way, you can't predilate here. You can't inflate a balloon if you are not sure that your wire is in the true lumen. So if you are no retrograde visualization, the only way is to do a tip injection.
Okay. This is another view. when I was sure that I was in the main lumen of the LAD, I started to dilate it. And through the filter, I have difficulty to introduce the filter at this level where I inflate the balloon when I start to use the filter XTR. But after, I think this was a little bit calcified or severely diseased, despite the stump, it was very difficult. But when I reached at the mid of the LAD, post bifurcation, the filter went so smoothly. So the hardest part was at level of this area after the bifurcation, this 10 to 15 millimeter after the bifurcation. And this is I stanted from up till down, and this is the final result. And then I went to the RCA and I crossed it with the Whisper extra support wire, and it went fine. And patient still doing fine. We did him Coro a few weeks ago. It was fine. Both are recanalized, the right and the LAD is still patent, and the ejection fraction is 50%.
Dr. Avran, I want to ask about stenting. About the stenting, we know that I learned for my fellows when they pass with in the cath lab that we generally balloon from the proximal to the distal part. In stenting, we have in normal cases to stent from the distal part till the proximal part. Is this strategy still working in CTO lesion? Because when we have hematoma, we know that we go from lumen to lumen, and most likely the proximal cap, we know where we are. The distal cap is more difficult to know where to land our stand, like the case of Dr. Sarhal, and we asked about it and we discussed about it. What do you think about that? Dr. Abou Jaoude. In normal way, in normal coronary angioplasty, generally we balloon from the proximal to the distal, and we stent from the distal to proximal. But in CTOs, like in the case of Dr. Sarhal and Dr. Kalakesh, we have a calcified lesion, and when we have an hematoma, we know most likely the proximal landing zone, because we know that is the true lumen. And the distal landing is more difficult for us. Do you do this strategy, stenting from distal to proximal in the CTOs, or to stent from proximal to distal inversely that we do in our daily practice in stenting?
In general, we respect the classical rule is to put a stent from distal to proximal. I believe in sometimes we all want to start by we want to fix the proximal part. In some special cases, for example, dissection, I want to see exactly, I want to do an injection, etc. Sometimes we want to start from the proximal, but in general, we have to start from distal to proximal. And no worry if we are in the subintimal lumen, in the new lumen. So no worry if we do a overlap of the stents. It's not a big deal. Sometimes you can do overlap to adjust your position of the stand. No worry about putting here an overlap of the stand, but you have always, and this is a rule, to do a post dilation, over dilation, etc., to have a good result by the end.
That's one comment, Ali. Two reasons. Usually I start my career from distal to proximal. And usually if you stand from proximal to distal, usually you have some problems in introducing stent in stent. So if it's easiest for you, start distal to proximal, unless you have an inlet LAD. So you have to start proximal to distal. Then you can't measure how much. Either the stent will protrude into the left main, or you have to make more overlap of the two stents. So if you have an osseal circ or osseal LLD, start proximal to distal. If you have an area of landing, good area of landing, start distal to proximal. It's easier.
Dr. Avran, we are discussing how put
Sorry.
stenting in the CTOs. And for you, this question is still going on. And the second question is really when we have hematoma and we have this dissection reentry in a right coronary artery on an LAD, but we don't have the IVUS in our daily practice, and we cannot do it frequently. How will take the size of the stent and this in this hematoma? Do really we need to inflate and to oversize the stent, or going to approximately what we think this is the good diameter of the stent? What you tell us about that?
Yes. So it depends. So it depends, because this case is very different, because this case is an acute coronary syndrome and with no visualization of the distality. But when you have a visualization of the distality, you know exactly the minimum. So we know that it means that be open, it will growing through the weeks and through the months. Place stand that diameter you thought visually, because the artery will grow. So if you control the patient, and we saw it with the previous case, the stenting of the RCA, the distal part of the PL branch was very, very tiny, and after 5 weeks, it grows a lot. So my idea is, as you said, stenting from distal to proximal, doing overlapping as right. Just be careful when you want to do overlapping, not to overlap in front of a side branch or a big diagonal, for example, because in front of. So just be careful, no overlapping in front of a side branch. And then I choose my the diameter of my stent without IVUS, just visually. And for example, if you have a RCA occlusion, just check the proximal part of the RCA, and you know approximately the size of the distal part. So I think you don't need IVUS to check the size of the vessel, but you need visualization.
Okay, excellent. Another question: when you have here to you, when you have this diffuse heavy calcification of the LAD, really, it's very calcified.
Yes.
We are not sure that the final result is excellent, will be excellent. Okay, because we have to put many stents or long stents. Do you suggest in this case to start by plaque modification, a calcified plaque modification, for example, by rotablator, by very high pressure balloon before stenting? Because in this case, heavy calcification, diffuse disease, long disease, the risk of restenosis is high. Here, if we do not do an excellent preparation of the vessel before stenting, what do you suggest? What do you recommend, Dr. Avran?
Yeah, you're totally right, and you already answered the question. I think that the first step is to use non-compliant balloon to be sure that the balloon is well expanded. if the balloon is not well expanded, you can use high pressure balloon, and not, you have to use a percent will be under expanding because of the calcification. So you're totally right. I think in that situation, first step is non-compliant balloon. And if non-compliant balloon is well expanded, you can, you are not forced to use a rotablation. But if non-compliant balloon is not well expanding, then you have to use rotablation. Yes, plaque modification is very important.
Dr. Avran, just two questions we learned with experience. Before the era of the microcatheter, when we were in such situation, we used to modify the wire till the apical LAD and then pull it back and shift it into 1 or 2 septals to make sure that we are in a true lumen. Another thing we used to do, we have to introduce the over-the-wire balloon till the end and use a small syringe, that of the insulin, to suck a little bit of blood. And that will help us to make sure the trick of the wire and the trick of the over-the-wire balloon to make sure that we are in the true lumen.
So it's a very good tips and tricks. But first, it's very important to show that your wire is going in different branches. But you don't know, if you have no visualization, which one is the septal, which one is the LAD. It's very hard, sure, because sometimes you have some septal which are parallel to the LAD. So it seems that the curse of the wire is in the LAD, but you are finally in a small septal. So if you make some predilatation here, it's a mistake.
Definitely.
And use insulin. Okay, but you are to be sure that there is no hematoma, because sometimes reflow could be hematoma if you are in subintimal space.
Yes.
So you have to be careful. If you are not using any, if you are not using any knuckle to go to advance your wire, or you are pretty sure that you are not subintimal, if you are reflow, it means that you are in a lumen, but you don't know which one.
Yeah, sure.
Okay.
Okay.
So very hard to be sure. But you can, if you have reflow, you can inject a little bit of contrast inside your over-the-wire balloon just to check where you are.
Yes.
Thank you, Mohammad, for this lovely case. And we'll proceed with Dr. Avran about his take-home message and some issues about tools that we use in daily practice for non-CTO lesion. Dr. Avran, the platform is yours.
Thank you. Okay. Do you hear me? It's okay?
Yeah, very good. We are hear you, but sometimes it's disconnecting, but now is very good.
Thanks. Okay, so it was a very first. I'm very honored to be inviting in your webinar. I think it's very important just to keep our relationships together in that dark time, as you said in introduction. A lot of things have been said, and a very important of message was said, and I just want to summarize that we can have in our cat lab CTO tools, and we can use these CTO tools, CTO devices, CTO technique for a non-CTO PCI intervention. So you show some of them, but I can show you a little bit more. For example, when your wire is crossing a very complex stenosis, calcified, tiny stenosis, and your balloon is not following and is not crossing. You can use some anchoring technique. As you can see here, just place the wire in a side and the balloon need to be at the size of the branches, and then you can use this increasing of support to advance your balloon to cross the stenosis. So this is anchoring technique. It's easy to do. You can do it in 6 French. This is the first one. The second technique is, as you said, you use a lot of over-the-wire balloon. But my question is, how to remove this over-the-wire balloon when you use it and your wire is in the distal part of your artery? So you can use long wire, you can use extension of wire, dock extension, but also you can use the trapping technique, which is a technique of CTO operator. It means that you just remove your over-the-wire balloon inside your guiding catheter, and parallel inside the guiding catheter, just place a balloon. So if you work in 6 French, it's a 2.0 balloon. If you work in 7 French, it's a 2.5 balloon. You inflate your balloon inside the guiding catheter, but after the position of your over-the-wire balloon. Then when you inflate your balloon, the balloon stuck the wire, and you can remove your over-the-wire balloon like this without removing the wire. So it's very important to know this, some very basic technique, but it is CTO technique. Second, how to increase my support when my guiding catheter is not very coaxial and the support is not so good. So first, everyone knows now this tips and tricks is using guiding catheter extension. So I know it is a Terimo webinar. I thanks a lot Terimo. Terimo has a very good guiding extension. It's an over-the-wire one named Earth Trail. It's very good and it's very useful when you are not in the good position. For example, with a Jenkins right, you have no support, or with Amplats, you are not absolutely coaxial. So it's very difficult to advance the wire and to advance the stent. So using this kind of devices could make your life easier in some situation. So when you have a complex calcified stenosis, so you see this example, it's not a CTO. There is a CTO on the RCA, but the LED, as you said, it's very calcified. It is not stent, it's only calcification. Stent, it's calcification. There is a stenosis in the proximal part, and the second stenosis very tiny in the distal part. So as you said, here with a normal workhouse wire, I was unable to cross this tiny part. So what I did is I was with a workhouse wire, like a run-through wire, just in front of this part, then advance a microcatheter and exchange my wire for a CTO wire, a very tapered one, like Fielder XT, as you said, or Gaia first. Just, it's not an occlusion, but I just need to be very careful and not going under the plaque of this calcification, and just try to find a way to cross. So here it's feeder XT, and you see the feeder XT, the tapered part, was able to cross and get inside the distal part of the LED. But it's not finished. As I told you, and as you asked me how to do with some calcification, so you can see here, I use a non-compliant can an extension my I just finally the first stenosis was able to be dilated with a non-compliant balloon, high pressure balloon, but this one I was unable to cross with any balloon. So I just move down my extension of guiding catheter to increase my support and also get back with my microcatheter to cross this part. And why I want to use a microcatheter in that situation? I want to exchange for a rota wire. And this is also a way to use some CTO devices for non-CTO intervention. Here, without the microcatheter, I really don't think that my rota wire will be able to cross this part. So, and now my rota wire is in the LED. I just remove my fine cross and go with a burr of rota, 1.75, and then modify the, as you said, and now it will be easier to cross with a long stent and also non-compliant balloon. And this is the final result with two long stents. Then sometimes you are in front of some complex bifurcation, and the use of dual lumen microcatheter will be a very important help in that situation. For example, this one, you can see this is a bifurcation between a diagonal and an LED. And there is some stenosis just after a small aneurysm at the bifurcation point. The diagonal, but impossible to take the inside the LED. So what I did, I used a dual lumen. So the dual lumen is coming. So it's a fine duo. Fine duo is a dual lumen microcatheter from Terumo. So my dual lumen microcatheter is going in. A little bit the part of the LED. So one wire is in, the other one is entering inside this curvy LED part. And finally, with the help of this dual lumen microcatheter, because you have the support is a little bit higher with this kind of dual lumen microcatheter, and I was deeper inside the LED. And finally, as you see, I was able to cross and to get inside the distal part of the LED and finalize my bifurcation. So this is just to show you the curvy part. And this is the final result. So this is one example. So this is Duo, for example. So it's very useful tools. So I know it's expensive, but sometimes it's the only way to succeed in some very complex case. Another example, you can see man. So it was graphed on the LED, but the circ was not graphed.
Alexandre, we have an issue. We don't hear you at all.
It's okay. You hear me?
No, yeah, we hear you back, but we have a lot of problem to hear you. You have
It's better now.
So it's better now.
Do
yeah.
you saw this
Yeah,
or
you can,
not?
we saw the double lumen microcatheter, but the explication about the double lumen microcatheter, we didn't hear it because there are no voice. You can take off your video and only stop the video. We can have more better sound with you. Shut.
Yes, okay.
Yeah, take
No,
off
it's
the
okay.
video. Yeah.
So
We don't hear you now. We don't hear you now. If you
sorry.
can, yeah, can put off your video and we'll continue without without video, but we will see your slides. It's better. We'll have a better connection then. That will run faster.
Like this, but you can see my.
Share your screen, but put off your video. Yeah.
Okay. Sorry.
Okay.
Okay.
Yeah.
Okay.
Okay. It's better. We'll hear you better
sorry,
then.
Sorry.
Yeah.
Okay. So I just you need to go. I go back or not?
Yeah. Now this. Yeah, you can. We heard the last. You talk about the double lumen microcatheter.
Okay, good.
And you continue from there.
Okay, so this is the fine duo. So fine duo is a dual lumen microcatheter from Terumo, and then you can see where is the second wire is exiting. So few millimeter before the tip of the wire. So one wire is monorail. So the distal one is monorail, and the side one is over the wire. Okay. So just to show you where it's exiting. So this kind of complex case, so you can see distal left main, very tiny stenosis. On the LED, but not on the circ. So the point was to delay the left main and the circ. You can appreciate here. So visually, we were very confident that the wire will go inside the circ. But finally, when we went with our wire, the wire went easily inside the LED, but impossible to get inside the circ. So how to deal with that situation? Using a second wire, maybe, but it will go also in the LED. The second option was to use also a fine duo, a dual lumen microcatheter. And you can see that the fine duo is, I just first inflate a little bit to facilitate the curse of the fine duo. Then this is the fine duo. The fine duo is going inside the LED. I'm just going with a second wire, a curvy one, inside the LED with my dual lumen microcatheter, then removing my dual lumen microcatheter, and then removing very, very slowly the to get inside the circ. You can see the LED. Then I remove my dual lumen, and then the second wire easily went inside the circ. So this is to explain you how some CTO devices can help you in some very complex non-CTO intervention situation. And this is the final result. And we save like this, this big circ. So here it's a step that you already discussed, the use of microcatheter in some acute coronary syndrome. Most of time when your wire cross the occluded artery, there is some flow, but sometimes there is no flow. And you need to be sure that where is your wire before going to a predilatation. So the only way, as I explained to you, is to do tip injection. So you see here, I was not sure that I was inside the true vessel. And you can see that I thought I was inside the LED, but finally I was inside a diagonal branch. So then I can correct my position. In that situation, it was RCA occlusion, acute coronary syndrome. And then you can see that the tip injection show me that I am in the true lumen before the crux. So to conclude, you have seen that CTO tools, I think in every cath lab there is guiding extension. And there is, I know microcatheter is quite expensive in some country, and maybe you can use over the wire balloon. Also, it's cheaper, but in some situation, microcatheter is still the gold standard. You have seen also the utility and the use of dual lumen microcatheter. Also, you can use CTO wire in some situation of PCI. You have seen a very tiny stenosis, calcified, so you need a tapered wire like feeder XT. In some situation, you need to recross some strut from a bifurcation. Pilot 200 might be the right wire in that situation. Also, using some coils might save you in some PCI situation if your wire makes some distal perforation. And I show you also some CTO technique, anchoring, trapping, and the tip injection. So thank you so much. I hope the connection was not so bad. And I get back my video.
Thank you, Dr. Avran. You are talking from Nancy, I suppose?
Yeah, absolutely.
It's too cold. It's too cold.
Yes.
It's snowing, I think. Okay. So it's snowing even in Lebanon now. Dr. Avran, thank you. Yeah. Finally, as you see, the aim of this topic today is to see and to show to everybody that the techniques and tools and some tip and tricks specialized for CTO can be used to facilitate our everyday procedures. For example, we can increase our backup by long sheath, by larger catheter, by anchoring balloon, by catheter extensor. Okay, we can increase our backup. We can use some specialized wires, like the doctors showed us their case. some specialized technique. The first case we saw today, we used a star technique to solve an acute MI with large dissection. So we can, some devices like dual lumen microcatheter, the microcatheter, the supercross, there are many tools we can use. We use every day in CTO procedure. They can be used to facilitate our everyday angioplasties and procedures. And even though we can use sometimes some complex for complex lesions, for example, an uncrossable lesion, calcified lesion, we cannot cross in any way. We can do some techniques, for example, dissection, anterior dissection and re-entry to cross this uncrossable lesion, to go through the subintimal layer. So, as I mentioned, CTO techniques, CTO materials, CTO tip and tricks must be mastered by our new interventional cardiologist to tackle more and more difficult procedure in the future. Okay.
Absolutely.
Thank you again, Dr. Avran. Thank you, everybody. Ali.
Thank you, Dr. Avran, for sharing this session with us. Thank you all the participants in all Lebanon and abroad. Thank you for the presenter, Dr. Saha and Dr. Kalakesh. Thank you, Dr. Fadi, for your input in this webinar, and hope to see all of you in the next session next Wednesday that will be tackling calcified lesion and strategy about this calcified lesion. Thank you, Dr. Avran. Thank you all.
No, thank you. Thank you so much, Ali, for the invitation. Thank you, all my Lebanese friends. And I hope to see you soon.
Thank you. What were?
Do you have CTO?
Sorry. But where we can see you the next time, in Nice or in Lebanon? Or the MLCTO, where will be the MLCTO meeting?
MLCTO will be in Nice, and then so it will be beginning of July. So we hope that I think we will do an hybrid one with attendees and with also web streaming sharing. So it will be a hybrid one.
Oh, nice.
Yeah. So and coming in Lebanon, yeah, I just received my first dose of vaccine 1 week ago. So I think.
So the confinement will be only 2 days in Lebanon if you are vaccinated.
Perfect.
Okay. Thank you.
Okay. See you soon.
Thank you. Thank you very much. See you soon.